So good morning, and I'm sorry if everybody is prostate cancer infoed out from the ICPC conference, but I hope I'll bring some new information today to you. I was going to talk about the management of hormone refractory prostate cancer and go into some of the new tricks that I think have percolated up as standard therapy now, and as well talk about some of the stuff that's upcoming in our clinical trials. So I'll start off by defining the patient population and the changing face of that patient population, and then go into the current management, or what I see as the current standard of management, including second-line hormonal therapies, chemotherapy, bisphosphonates, and then end up on the last half of the talk talking about new tricks, some of the novel therapies we're working on in the clinic, and including some new data. So this is what hormone refractory prostate cancer was in the past. Basically, patients were presenting after their castration therapy with symptomatic bony metastases, extensive disease, poor bone marrow function, and a very poor survival around 6 to 10 months. And essentially, whatever the cancer, if you're showing up at this kind of stage of the disease with that kind of poor marrow function, poor performance status, poor survival, there's really little that can be done. I would say that still a lot of my colleagues still see hormone refractory prostate cancer as just this. I think it really has changed, though, in this era of the use of PSA for monitoring, and furthermore, more especially probably, is the early use of hormone therapy prior to patients having metastases or symptoms. Certainly, we're seeing a huge group of patients in this level here, as hormone refractory prostate cancer is now just being defined as a serial rise in PSA with just castrate level of testosterone. So you have this big group of patients with just biochemical only disease, so just PSA only as their marker of disease. These patients can have a long survival, and this is somewhat emerging data as some of these trials are coming out in these patients, but it's probably in the 24-plus months range. Even as well, we're getting a large group of patients in this kind of section, which is clinical metastases without symptoms. And this, again, is from the PSA era, a wide use and easy availability of imaging and bone scanning to detect metastases. And these patients, again, have a good survival of 18 to 24 months in a lot of studies that are coming out now. And then finally, even symptomatic metastases, I think these patients are also doing better as they're being picked up earlier. There's more awareness, and their survival is probably getting into that 12 to 18-month range. So there is indeed been a change in hormone refractory prostate cancer, but in essentially a stage migration. So you have a larger population of patients that are well. They know what's going to happen, that's inevitable, and they're demanding more effective treatment options. I also think this stage migration has a significant effect on how we need to look at the trials that are coming out, especially the single-arm trials. So often you're seeing response rates of anywhere from 60 to 80% in hormone refractory prostate cancer, but what we're seeing is that these patients are often in this range, or even in this range or in this range. So these are well patients that have low burden of disease and a good performance status. And any cancer, those patients always do better. They always have a higher response rate. We've seen the same things happen with breast cancer, with lung cancer. As patients were treated earlier, response rates rose, but not necessarily changing the natural history. I'm going to frame, the rest of this talk is just going to be basically on the management. And I'm going to frame it around this slide, which is taken from a review of mechanisms of androgen independence. And I think it nicely summarizes these mechanisms. And first off, one of the major things is activation of the androgen receptor in the absence of androgens. And that can be through several mechanisms, including the hypersensitive pathway, whereby the androgen receptor is just more sensitive to smaller levels of androgen or testosterone. The promiscuous, whereby the androgen receptor is activated by other ligands, such as flutamide or adrenal androgens, etc., or through outlaw, so it's a ligand-independent activation of the androgen receptor, for example, from upstream growth factor receptors, resulting in activation of the androgen receptor and thereby activation of androgen receptor-regulated genes, resulting in growth and survival. So our first line of attack, and so I'm going to frame the management around this. It gives us a rationale for how we treat our patients. So our first line of treatment is usually second-line hormonal maneuvers, whereby we're trying to target that androgen receptor to induce a response. surprisingly, well, at least to me as a medical oncologist, the evidence for second-line hormonal maneuvers is actually very sparse in prostate cancer, compared to, for example, breast cancer, where we know first, second, third, and really even fourth-line hormonal therapies, we have the response rates well worked out as well as the survival benefits worked out. In the case of hormone refractory prostate cancer, that really doesn't exist, and I tried doing a literature search and found only a couple of trials whereby there was a randomized controlled trial comparing second-line hormonal maneuvers. One of these, the first one, is an EORCT trial where they compared flutamide versus prednisone, and they took symptomatic patients. It was started in the early 90s, and they basically shut it down after a while because it wasn't accruing very well, and they had 201 patients, so symptomatic patients. They thought that actually prednisone or flutamide would do better than prednisone. Prednisone being just a non-specific adrenal gland blocker, thereby decreasing the secretion of adrenal androgens, whereas flutamide would be a more specific androgen receptor blocker. So they thought flutamide would be better, but indeed it was about the same. So PSA response rate was about this 20% range, which is kind of consistent across all these second-line hormonal maneuver type trials. The PSA response rate ends up being about 20%. Surprisingly, the palliative response rate with prednisone was higher, 56% versus 45% for flutamide, and there was more patients with side effects from the flutamide, like diarrhea, GI side effects mostly. The palliative response rate was defined as by physicians, so they were the ones that marked down patients better, yes, no, and we know that's probably actually quite wrong, and that physicians are not very good at predicting whether patients feel better or not. So in the end, we're really just left with a response rate of about 20% from this randomized controlled trial. Other nonsteroidal antiandrogens as second-line maneuvers have also been looked at. This is a large trial, bicalutamide, 150 milligrams, phase 2 multi-center SWOG trial, PSA response rate 20%. Nilutamide, this is a retrospective selective consecutive patient, so just really a case series, PSA response rate of 50%. So indeed, there seems to be this PSA response rate associated with the use of nonsteroidal antiandrogens, and some of those patients on nilutamide had previously received other nonsteroidal antiandrogens. It's really who responds is unknown. Multivariate analysis have looked at, who can we select out the patients that are more likely to respond, and really there was nothing that came up. Other forms of second-line hormonal maneuvers include, well, if you've got them on a nonsteroidal antiandrogen, one thing you can do is do antiandrogen withdrawal. So sometimes these nonsteroidal antiandrogens, by binding to the androgen receptor, actually cause activation of it. And so by withdrawing it or stopping the flutamide, nilutamide, bicalutamide, you can induce a regression. And initially it was described in occurring upwards of 30% of patients. I also saw some 50% of patients. Well, in this large randomized controlled trial by CALGB, they looked at antiandrogen withdrawal, and it was about 11%. And from kind of my clinical experience, I think that's what I see. It's a very low rate of response, 10 or 11%. So it's not something I count on or wait for if I'm treating a patient. They also look at ketoconazole, and that's another popular regimen in the United States where they give high-dose ketoconazole. And what this is doing is shutting down corticosteroid synthesis in the adrenal gland. And they saw a response rate about 30%. The purpose of the trial was seeing if the combination was better than single agent or consecutive treatment, and really it wasn't. So whether you do antiandrogen withdrawal alone plus the ketoconazole or one then the other doesn't really matter. But you're seeing this response rate of around 30%, 20 to 30%. Now, what is remarkable is that these patients were all very well. Most of them were asymptomatic. So again, it's on that other end of the spectrum where patients would just have PSA-only disease as opposed to that EORTC trial, which was looking at patients with more advanced symptomatic disease. So the fact that the response rates are about 30% are not that remarkable. Other trials have shown lower doses of ketoconazole may be just as effective, 600 milligrams a day. High-dose ketoconazole can be pretty toxic, fatiguing, can have effects on the liver and the kidney. And my question is this just the effects of the corticosteroids alone? Just giving the prednisone gives a 20% response rate in symptomatic patients, while in asymptomatic, maybe you're getting this 30% PSA response rate. So really that's all I found from randomized controlled trials. And so we have a paucity of information to really guide us on how we go forward with that. So you have many options. You can initiate maximum androgen blockade, start corticosteroids, antiandrogen withdrawal, ketoconazole and hydrocortisone, or switching antiandrogens. But I think the clinical impact is of question. It's not been well defined, and are we really changing natural history for populations of patients? For individuals, I think, yes, we benefit, but they may be a very small proportion, and we may not be changing the natural history. But it's well tolerated. You get some very good biochemical and symptomatic responses occasionally. And I think it's an appropriate line of therapy for asymptomatic patients or chemotherapy-ineligible patients. I think for symptomatic patients, I think we have other treatments, which I'll talk about, that we should just get right into rather than wasting time switching around hormonal therapies. Not that I know of. I've never seen that, no. Surprisingly, it'd be an easy study just to do and look at PSA response rate. Anecdotally, though, I've had some patients on steroids given ketoconazole and respond to it, so there may be something to that. But they could have just responded to a higher dose of steroids. I don't know. So after second-line hormonal maneuvers fail, the next thing is chemotherapy, which really ignores mechanisms of androgen independence, and the development of chemotherapy has largely been empiric, basically taking a bunch of drugs, banging it into people, and seeing if it works. And this is data from earlier trials in the 80s and early 90s looking at these various agents with response rates all less than 10% and really earned the name of prostate cancer as being a chemo-resistant disease. So focus moved more towards looking at chemotherapy as a palliative treatment. And I bring this up is because Dr. Tanig gets a lot of credit for developing mitoxantrone as a palliative treatment for prostate cancer. But it's actually Chris Coffin's idea. He just never really carried it forward. And Nevin Murray is first presented data on mitoxantrone in hormone refractory prostate cancer using a symptomatic response rate. And it was actually Chris that kind of developed this concept and actually discussed it with Ian Tanik. At least that's what Chris Coffin tells me. But they never took it beyond this. And Nevin tells me he did this because he just wanted to go to Japan for a presentation. But Ian Tanik is the one that actually really developed this and established mitoxantrone as a standard chemotherapy for palliation. And they did a trial, and instead of looking at response rate or survival as their primary endpoint, they looked at the palliative response as their primary endpoint. They felt that these are older men, whacking them with high doses of chemotherapy is just going to make their lives miserable. And if you can't expect cure, why go for it? Why not just go for a different endpoint, which is palliative response? And it was strictly defined as a pain score and a change in the pain score. And indeed, with the mitoxantrone and prednisone arm, the palliative response rate was 29% versus just prednisone alone, that was 12%. Mitoxantrone is an extremely well-tolerated chemotherapy. It's given once every 3 weeks as an intravenous injection over half an hour. No hair loss, minimal nausea or vomiting. Chance of a severe side effect is well less than 5%. So it's a very well-tolerated chemotherapy for this elderly group of patients. And also they looked at a number of quality of life parameters and global quality of life, and it was better maintained on the mitoxantrone arm than on the steroid arm alone. Criticism of this could be that it was not a placebo-controlled trial, and if you're getting a 30% kind of response rate, then maybe it's just a whole placebo-control type thing. But I think there's other evidence suggesting that mitoxantrone is effective. For example, the PSA response rate, 50% PSA response rate of about 37.5% versus 20% for hydrocortisone alone. And this is very consistent with that EORTC trial, right? So symptomatic patients, steroids alone, about a 21% versus 37%. So there is some anti-cancer effect going along. This is from a CLGB trial by Kantoff, also looking at mitoxantrone versus steroids. Also, time to progression was delayed in the mitoxantrone arm, so here's mitoxantrone versus hydrocortisone. There is a bit of delay in time to progression, but overall survival is the same between the two groups. So I think there's an anti-cancer effect there, and there's this palliative benefit there. Fortunately, though, some new things are coming along, and that new thing is Docetaxel. And there's been, initially in the late 90s and early 2000s, there were several trials reporting the efficacy of Docetaxel or Taxotere in hormone refractory prostate cancer. Docetaxel is an antimicrotubule made from the needles of the European yew tree. Now it's semi-synthetic. And they looked at various regimens, once every 3 weeks and also weekly. By giving it once every 3 weeks is kind of standard. You get the dose about a week later, all your hair falls out, You get myelosuppression. About 80% of patients get myelosuppression, and a risk of febrile neutropenia of about 5 to 10%. But otherwise pretty well tolerated. Weekly was used because by giving it weekly, lower dose weekly, you actually get less myelosuppression. Only about a 50% chance of your hair falling out, but it is a 50% chance of your hair falling out, and plus you can get all your fingernails falling out, which can be quite uncomfortable. Also, fatigue is a major problem with the weekly chemotherapy. So with Q3 weekly, you get the chemotherapy, you get a bad week, but the other 2 weeks are good. With the weekly chemotherapy, my impression is that you just feel bad all the time. You're just getting this weekly. Although you don't get the toxic effects of the myelosuppression, you're getting this weekly treatment. But response rates, if you look at it and you kind of average these numbers out and looking at the end, it's about 30% actually, or about 39%. If you recall the Mitoxantrone trial, it was about 37% in symptomatic patients. Most of these patients are asymptomatic. So the PSA response rate isn't a whole lot better. What was remarkable, though, I think, from these trials is that the objective response rate is in the 30% range. With Mitoxantrone, the objective response rate, that means actually shrinking cancer, is only about 5%. But here with the Docetaxel, we're seeing 30%. And indeed, we moved to using Docetaxel in selected patients quite early on, before any phase 3 trials, kind of a first in BCCA experience, I guess. And this is just an example. One of my patients who had massive lymphadenopathy, he also had massive local recurrence, very uncomfortable, young guy, and we treated him with Docetaxel, and this is his response. And that was a couple of years ago now, and he's still doing well. So this is a guy with bona fide hormone refractory symptomatic disease. He's done extremely well with this shrinkage of disease, and he's maintained this response for a long time. So that, to me, that was quite remarkable. This has gone on to a phase 3 trial, 1,000 patients, the largest randomized controlled trial in hormone refractory prostate cancer, randomizing patients between Q3 weekly, Q weekly, and Mitoxantrone. And this is a plenary session at ASCO 2004. So obviously, it's not a negative trial. I'm not allowed to say anything. I know, Martin, you got up and made some comments at ICPC, I heard, but unfortunately, I'm not allowed to say anything. In terms of the details of that trial or the results of it. I don't think it's necessary.
But the actual rules are that in meetings that
I know.
You can actually talk about the results.
I know. I was at a meeting. They stood up and they expressly said, nobody can talk about it. No rounds, nothing. And we all had to sign these agreements to do that. Yeah. So for us, you don't have to say anything. I did. So Docetaxel estamustine, that's another combination that was very popular. Estamustine is a nitrogen mustard connected with estradiol, and initially it was thought to be a targeting type agent, chemohormonal type agent for breast cancer, but didn't really work there. So moved into prostate cancer, and in preclinical studies, looked like it had synergy with Docetaxel. And indeed, in these phase 2 trials, very high response rates, so like 70-80%, with good objective response rates, quite high as well, 50% range. Again, you have to look at the patient population. It's a very good patient population that they were studying in all these trials. And this has also moved into a randomized controlled trial, Docetaxel estamustine versus Mitoxantrone, and this is also a plenary session at ASCO, so obviously not a negative trial. So again, I can't really talk about the results, but maybe I'll just summarize it this way. So summary chemotherapy, Mitoxantrone is demonstrated palliative patient benefit. It's well tolerated, and I think still useful for a number of patients. Docetaxel, I haven't changed my practice. Well, I have actually. I actually just use Q3 weekly Docetaxel now. And I think that's appropriate. That's a standard across BC. I don't know if all the medical oncologists are using it, but certainly us in Vancouver are. And Docetaxel is the basis for all future trials in hormone refractory prostate cancer. So the other treatment that's emerged as perhaps raising more questions about its usefulness, though, but with a positive trial, is the use of bisphosphonates in prostate cancer. So bisphosphonates are stable analogs of pyrophosphate. They decrease depth and rate of formation of bone remodeling units. So bone remodeling units, our bone is constantly being turned over. There's a destruction of the bone and then laying down of new bone. And what these bisphosphonates do is basically poison this bone remodeling unit. So in osteoporosis or lytic cancer, there is, like breast and myeloma, there's a more destructive balance to the bone remodeling unit. And something like prostate cancer, which has a more sclerotic component, there's more laying down. But in both cases, there's activity of that bone remodeling unit. So poisoning that bone remodeling unit may help with bony metastases. And indeed, a number of bisphosphonates are active in other cancers, such as breast and myeloma. A lot of their effect, though, you have to remember, is from hypercalcemia, preventing hypercalcemia. It's a lesser effect on this sort of other skeletal-related events. Now, in prostate cancer, there have actually been a number of trials with bisphosphonates. They've all been negative. Clodronate, pamidronate, all of these things have been negative, except for one trial. And what was different about that trial, well, it used skeletal-related events as the primary endpoint. So, that's one flag of caution that's going up. As opposed to other cancers where there's a class effect, in prostate cancer, it's not so clear if there's a class effect. This trial was zoledronic acid versus placebo in patients with prostate cancer that were hormone refractory and had metastases. And they used their primary endpoint as skeletal-related events, which are actually quite clinical. So pathologic fractures, spinal cord compression, radiation to bone pain, surgery to bone, or change of anti-neoplastic therapy for bone pain. So quite a practical endpoint. Hypercalcemia and malignancy was also included, but that's basically a rubber stamp from the breast and myeloma trials. This trial looked at 643 patients and randomized them between zoledronic acid 4 milligrams, 8 milligrams of placebo. 8 milligrams was too toxic, so they dropped it down to 4 milligrams, and patients were treated every 3 weeks for 15 months. And this is just a breakdown of what happened to these patients. So it was a very well conducted trial, and right off the bat you see that, for example, patients dropped off for unsatisfactory therapeutic effect more so in the placebo arms than the zoledronate arms. Adverse events were about the same across, maybe a little bit more, of course, in the zoledronic arms. And overall, there's more discontinuations probably in the placebo arm. It was well tolerated. Some people make that, there's some of this myalgias, arthralgias, and that there's more toxic effects on the zoledronic acid arms. But really, the numbers are small, and I think overall it's a very well tolerated medication. And for the primary endpoint, indeed, there's a difference. For the group of patients, there was 33% of patients in the Zometa 4 milligram arm had a skeletal-related event versus 44% in the placebo arm, so an absolute difference of 11%. And we'll get into the interpretation of that in a minute. With the Zometa 8 milligram arm, there wasn't a statistically significant difference. And one of the things they said, well, there's more people dropping off the Zometa 8 milligram arm. Well, that's actually kind of BS, because if you look at treatment duration, and duration on the trial is the same for all 3 arms. So what it is just a power thing, and that likely the true effect is somewhere in between these two, or the Zometa 4 and 8. It's probably somewhere in between. And this is what it looks like over time. Again, the 4 milligram arm more likely not to have a skeletal-related event than placebo, and therefore truth is probably somewhere in between here, between these 8 and 4 arms. So it's a positive trial. But what's the patient benefit? When I'm actually treating a patient, I think of two things. Am I going to make him live longer? And am I going to make his quality of life and pain better? Well, I actually don't know that from this trial. They did make some reference, and you'll see it in their advertisements, that pain is better, or there's better pain control on this. And in fact, when you look at it, and you see these scales of here's the Zometa arms versus the placebo arms, but it's missing here, but the y-axis is on a scale of 1, and the pain scale was out of 10. So these differences are less than 1 on a scale of 10, which is not considered clinically significant, although they may be statistically significant because of the numbers of patients. Analgesics and quality of life were not different, and survival was also not different. So I really don't know how I'm benefiting the patients in this. And then you look at wearing my BCCA hat is the cost effectiveness when we're trying to look at treating a population. The number needed to treat is 1 in 9, so I got to treat 9 people to benefit 1, which actually isn't too bad. If you look at some of these cardiovascular things, it's like number needed to treat is 20 to 1 or 50 to 1 in some of them. But it's an additional $32,000 per event avoided, and an additional $59,000 for each man and whom an event is avoided. So this is actually going above what sort of the usual accepted cost-effectiveness ratios are. We did put in a PEC proposal primarily because, I'll be honest, bisphosphonates are approved for breast cancer, and this is the same kind of benefit as in breast cancer. And so politically, and we felt that there was a positive trial that we would put this under PEC. But to be honest, in this Liberal government with a zero budget freeze, it's unlikely that it'll get approved. However, it is available under the Palliative Drug Benefit Program. So for the last half of the talk, I'm going to talk about some of the new tricks that we're getting into, and specifically going into some of the targeted therapies, which is the key word. So moving from targeted therapy of the androgen receptor to sort of empiric, just killing of cancer cells with chemotherapy, and now we're moving back to targeted therapy. And this time looking at some other pathways that are activating cancer cells. And a big one is growth factors. There's two equations to cancer. There's growth as well as lack of death, or so more likely to survive. And a lot of the focus in cancer has been on the growth end, or the proliferation end of things, and hitting that. And indeed, one of the key targets have been growth factor receptors. The other side of the equation is apoptosis, or trying to enhance apoptosis, which is cell death. And there's less that has been going on in there. Some of the stuff that that is going on nationally, internationally, and that we may become involved with is, for example, bevacizumab, which is a monoclonal antibody against vascular endothelial growth factor, which in a phase 2 trial showed promising response rate with docetaxel, and that's being taken forward in a randomized controlled trial, probably through the intergroup mechanism. IRESA, which is a small molecule inhibitor of these growth factor receptors, it's preventing this downstream signaling getting into the nucleus and changing things, was tried in an NCIC trial. We're about to open a trial of this drug, Bear 439006. This is quite exciting drug. It actually induces responses in kidney cancers. And if it can induce responses in kidney cancers, boy, that's pretty exciting, I think. And so what it's doing is targeting RAS kinase, but also targeting the VEGF receptor. So it's a bit of a dirty, what I call a dirty small molecule inhibitor, as opposed to these like IRESA, which is very specific. It only takes out one target. What we're actually seeing is some of these more dirty kinase inhibitors having more activities and more cancers. Makes sense, if you take out one specific molecular target, unlikely to have a good effect as if you're taking out a bunch of them. Cancer is a heterogeneous problem. The other thing is going after survival factors, and some of the stuff that we've done in Vancouver. One is participated in a large randomized phase 2/3 trial with calcitriol, and I think Tom Beer, that's work that Tom Beer's been spearheading. And stuff in Vancouver is BCL2 and clustrin, and I'm going to focus the rest on this on BCL2 and clustrin as targets for enhancing apoptosis. So I'm sure you've heard a lot about this, so I'm just going to kind of go through a brief introduction and go more into the data from the trials and what we've done. So BCL2 is a B-cell lymphoma leukemia-associated gene 2, and it was discovered through the 14/18 translocation in low-grade lymphomas, and it's kind of pathognomonic of that cancer. What it does is it's at the level of the mitochondrial membrane. So you get this death signal going in. This death signal goes, which is induced by either chemotherapy or radiation, goes to the mitochondria, and then the mitochondria kind of makes this decision, live or die. And part of that decision is based on BCL2. If you don't have a lot of BCL2 around, but a lot of BAX, what happens is that death signal goes forward, you get release of cytochrome C, caspase activation, and the cell gets chewed up. If you've got a lot of BCL2 around, it binds to BAX, prevents the formation of these pores, and prevents cytochrome C release, and therefore prevents apoptosis. BCL2 in prostate cancer seems important, and localized disease is correlated with high Gleason score, node positivity, and it's an independent negative predictive and prognostic factor. In relapse disease, there's a poor response to androgen withdrawal therapy, and in hormone refractory disease, there's reports of higher expression of BCL2. And in a lot of preclinical studies done by Martin and others, it's demonstrated it's implicated in the development of androgen independence. Interesting as well, taxanes phosphorylate BCL2, and docetaxel is the most potent phosphorylator of BCL2, and phosphorylating BCL2 inactivates it. So, that's a reason why docetaxel has emerged as such a good therapy for prostate cancer. So BCL2, we would like to target it. It seems like a great target, but trying to get a small molecule to target it has been very difficult. We all like small molecules. They're easy. They bind to it. We know it's working. But it's been very difficult to develop a small molecule inhibitor to BCL2. So an alternative way of targeting it may be through antisense oligonucleotides. And what these are, I'm sure you all know it here, but just to bring everybody up to speed, what these are short strands of single-stranded DNA that have been modified to resist nuclease degradation. If I just took regular native DNA and injected into it, it'd be gone in seconds as your body would just tear it apart. But these have been changed so that one of the non-bridging oxygen atoms is converted into a sulfur. And what this does is gives it a half-life of about 2 to 4 hours. Still pretty short. What these are, they're designed to be complementary to the message RNA of their target gene. So it's very specific. So it binds to BCL2 message RNA. Your body doesn't like that, activates an enzyme called RNase H and chews up the message, and therefore you don't get production of the BCL2 protein. There's been a lot of preclinical work done with this molecule in a whole bunch of cancers, and Martin's done a lot with the antisense to BCL2, and it's now in phase 1, 2, and 3 trials. So the question is, well, does it really work? There's a lot of negativism out there about antisense, and it's gone into phase 3 trials. This is the first one to finish, and I'm not sure if it's officially reported or not, but I've got the data, so here it is, and I'm not bound by any confidentiality agreements for this trial. So this is a randomized control trial of DTIC, which is a standard chemotherapy for melanoma, versus DTIC plus this antisense to BCL2. And it's, I think, the largest melanoma trial ever done, over, 700 patients there, 750 patients. Now, just looking at the DTIC arm, first of all, you see that progression-free survival and time to progression, pretty darn short, 50 days. But there's actually a doubling of these factors, and so the p-value is very significant. Response rate, 7%. That's our standard chemotherapy for melanoma. But it's almost double the gain using the antisense to BCL2. So I think there's something biologically going on here. So I think that's quite exciting, actually, and these are statistically significant endpoints. Problem is the primary endpoint is negative. If you look at the overall survival, although there's a separation of the curve here, the p-value is not significant. Part of the problem is that a lot of patients were enrolled at the end of the trial, and there's a lot of dropouts. All these little lines are where patients are dropped off on these Kaplan-Meier curves, so they're not factored into the survival after that point. So if you actually look at patients that either died or had significant or reasonable follow-up, there is actually a separation of the curves. And so there's two ways of analyzing things. One is an event analysis, when enough events have happened, and the other is waiting until you have more follow-up. That first slide showed an event analysis. This would be looking more when you're looking at enough follow-up, and there seems to be a separation in the curves, and there's going to be a reanalysis of the data later on this year, and perhaps that separation in the curves will persist. But even without this, it's gone to the FDA, and I suspect it'll actually get approved based on all that based on the time to progression, response rates, and everything else. Because, for example, IRESA, which has a 10% response rate in lung cancer, no survival benefit, no progression-free survival benefit or anything was approved, and I suspect the antisense to BCL2 will also get approved. So I think this is exciting.
Well, Mike, in such a short period of time, the time between, 1-2 months, it's like saying if you run all the way from 30, you've got cancer of the kidney all over, operate, and you live a month and a half longer. And so that's your own.
That's median, right? And so if you're looking at the population, that's just the median, and it's a single point in time. I think an alternative way of looking at it is you've got a 20% chance of being alive at any one point in time. A great 20% greater chance of being alive at any one point in time if you get this antisense. I think people would take that. I mean, that's another way of looking at it. Median survival is that point estimate. And it's difficult to wrap. I think it's difficult to wrap my head around that when I think about it. But when you think about a 20% improvement in your chance of being alive at any one time, I think that's more significant. Yeah, hey, we were using DTIC with a response rate of 6% in this disease, so I think any improvement is a good one. What we did in Vancouver, there's been a bunch of trials, but one thing I'm just going to build on the Docetaxel story that we joined with Tony Tolscher at the Institute for Drug Development and did this phase 2 trial of the antisense. with docetaxel in hormone refractory prostate cancer. And because it's got such a short half-life, you have to give these 7-day infusions through a central line, and it's kind of inconvenient. You get central line problems, so it's a bit of a hassle, but not too bad, and people accept it. And then chemotherapy was given on day 6. This is the patient population, and I think it was a typical Canadian population. Most of the patients were from Vancouver, and the ones from San Antonio, Tony actually said he got them. They crawled out from under a rock because they never got docetaxel in America, which is basically a standard therapy down there. And so these guys were pretty sick. I think overall they had heavily pre-treated. A lot of them had previous radiation for bony pain. All of them a lot of them had baseline fatigue, ECOG performance status 2. Some of them even had chemotherapy. 19% had chemotherapy. So I think there was a sick group of patients. And again, remember, looking at that scale, I think we were on the opposite end of that scale. It was well tolerated or similarly tolerated to docetaxel chemotherapy with the typical neutropenic side effects. Side effects specific to the antisense include fevers, non-neutropenic fevers, fatigue, aches and pains, kind of a flu-like illness that occurs from immune stimulation. Response rate was about 48%, which in this group of patients I think is reasonable. If we look at just the Vancouver patients, it was about 55%. Some of those San Antonio patients were, as I said, quite unwell. So it's on that upper range. Now, looking back, Mitoxantrone was about 30 to 40%. Docetaxel alone PSA response rate was about 39%, and perhaps are we pushing it up a little bit by that 25% up to a 48-50% mark? I don't know. Single arm trial, of course. What's more telling may be that we may not be increasing the number of responses, but perhaps we're improving the depth of response. And PSA progression, the median has not been reached, although we've had a lot of drop-off. But the median time to PSA progression was not reached at the last analysis. Usually it's about 3 or 4 months, which would be about at this time point here. So I think there seems to be a bit better. And overall survival in this group of patients is 605 days, so pushing that 18 to 24 month range. Some correlative studies were done. I just want to draw your attention to this, that responders, these are box plots of the concentration of the steady state concentration of the antisense in the blood. Responders had a higher concentration of the Genesense than non-responders did. So that brings up a few questions, so conclusions. So I think there's interesting activity. The PSA response rate was reasonable considering the patient population. It looked like good time to progression overall survival, but clearly not a home run. And some of the questions that need to be considered is drug. Do we need more? Are we getting enough in there? And that diagram showing that responders at higher steady state concentrations actually creates that hypothesis. Is the target not that important? Maybe there's all sorts of backups to BCL2, and blocking BCL2, it doesn't really do anything because there's BCLXL and all these other family members. And we also didn't look at the patient population. I have no idea whether these patients are expressing BCL2 in their cancers or not. And that's the difficulty with prostate cancer. I can't just go around biopsying all their bones to see if BCL2 was expressed. So it would have been nice to figure some of this out more, like getting a targeted population and actually experimenting with giving increases doses of the drug. But this is going ahead with a phase 3 trial. It's already planned, protocol's already written, and probably going to start by the third quarter 2004. I guess that actually also depends on what happens with Sanofi and whether they take over Aventis or Novartis Aventis or whatever happens with that. So that's in the works right now. The other target is clustering, and I'm sure you've probably heard a lot about this from Martin. And again, I'm just going to be brief on the background of it and just get into some of the new data from our trial on it. So clustering is associated with a lot of normal processes, including tissue remodeling, lipid transport, membrane protection, complement defense, and has been shown to be anti-apoptotic, and a lot of nice work by Martin. In malignancy and prostate cancer, there's low expression normal prostatic tissue. Increased expression correlates with higher Gleason grade, and there's an increased expression after neoadjuvant hormone therapy. It's also expressed in other cancers, including renal cancer, about 80% of renal cancers, bladder cancers, ovary, lung, and breast where it's a negative prognostic factor. And overexpression in preclinical models confers resistance to hormone, chemo, and radiation therapy. And I'm skipping over a lot of the background, but this is work from Martin and showing that by using antisense to the cluster, and again, it's difficult to develop a small molecule inhibitor to it, but using antisense to the cluster, you get enhanced apoptosis after castration in the Shionogi model, and then maintenance and better effect, longer suppression of the tumors as opposed to control, with after castration you get androgen-dependent regression and then hormone refractory growth. So using the antisense, you get a better effect from the hormone or castration therapy. And as a chemotherapist, I like this one. Here are these PC3 tumors. They're grown up. They're given chemotherapy with Taxol. Here's the control. So you get some regression, but then chemotherapy is given again, and you actually get just frank growth with it. So pretty resistant tumors, and these are very aggressive tumors. While if you give the antisense to clustering, you get a better regression, but also maintenance of that chemosensitivity. So I think that's really nice. What's going ahead is OGX-011, which is a second-generation antisense oligonucleotide. This is what's going into the clinic. So it's still a phosphorylthioate, but it also has this modification here. And what this results is in improved scheduling. It's a longer half-life, longer suppression of target. So instead of giving these weekly continuous IV infusions, you can give weekly bolusing. And so that's more maybe better tolerated on the patient perspective. It also has less non-specific toxicity, so perhaps we can give more. Instead of being limited by the dose we're giving from toxicity, we can give more of this to suppress the target. Now, when we're taking these things into clinic, there's a bunch of things that we need to think of, and one of the biggest things with targeted therapy is what is the right dose. With chemotherapy is easy. We just keep on giving more until they have bad side effects, and we back off and we say, oh, that was too much, so we're going to give this dose, right? So we try to give as much as possible. But with targeted therapies, we don't know how much to give because ultimately you have to know what's happening at the target level. And so the biologically effective dose may be a more important issue than maximally tolerated dose. This is what we generally use for chemotherapy, but for targeted therapy, we want to be using this dose. And that assessment of biological effectiveness has been difficult. Patients are usually not willing to get biopsies of their metastases to find out whether the drug is working or not. And oftentimes surrogate tissues are used, like peripheral blood mononuclear cells, or even just skin, doing skin biopsies and seeing if it's affecting it there. And I think as well, when we're thinking about the development of this compound, there's a lot of antisense skepticism in the world, and we have to be very definitive in how we show that whether this molecule works or not. So the trials that are going forward are two of them. They're being coordinated through the NCIC, but this was funded by the DoD and this was funded by the NCI Canada. And I think what was novel is this trial here for a first-in-man study, and it's a phase 1 trial using the agent plus neoadjuvant hormone therapy prior to radical prostatectomy. And what was neat about this is that the primary objective is to determine the toxicity and define a recommended phase 2 dose based on the biological effectiveness of it. And I think that's what was, and basically by giving the treatment prior to radical prostatectomy, we can get everybody's prostates and assess them for target tissue, i.e. the cancer in the prostate concentration, but as well whether it's actually affecting clustering expression in those target tissues. So far, this is the dose escalation. We started December 2002, and we're probably finished. We're debating on whether they're going up to that dose or not. Those are the number of patients accrued. So it's actually accrued very well for a phase 1 trial, especially incorporating the surgery into it. These are the patient characteristics. They had to have a high-risk feature. So far, it's been well tolerated, just some grade 1 toxicity. Lower hemoglobin, so that could be from hormone therapy, plus we're drawing a whole lot of blood samples from them, and so it could just be from that. They're getting the usual fatigue, fevers, and chills. They've been pretty pronounced in the 640 milligrams. So in the first week, they're getting infusions on Monday, Wednesday, Friday, and then Monday, and then their surgery. That first week is pretty toxic, actually. They get a lot of fevers and chills up to 39.5 degrees Celsius, a lot of fatigue. I tell most of them to take the day off work. But they're otherwise tolerating it well. And we're seeing some liver toxicity, which is common to other antisense oligonucleotides as well. It causes probably an inflammation of the liver. What's interesting is that after that first week, everybody recovers. The liver enzymes get better, and with the weekly infusions after that loading dose, it's extremely well tolerated. So here's some good data. It's getting into the tissues. So this is the tissue concentration of the antisense versus dose. And the higher we give, the more we get into the prostate tissue. So that's a good thing. And looking at RT-PCR of clustering expression of the message, it goes down. So here's some control patients. And here is escalating doses. So the more we give, the lower the message is. And if we look at the protein level, if we look at the number of cells or the percentage of cells that don't express clustering anymore, so zero expression, so I want that to go up. Initially, a lot of cells are expressing clustering, but then more and more cells, so upwards of 50% of cells are no longer expressing clustering. So I think that works. So I think that's exciting data. So it's well tolerated, dose escalation continues, and a phase 2 dose of OGX-011 will be determined based on optimal biologic effectiveness. And this is the first proof of principle demonstration of dose-dependent target inhibition for an antisense molecule. And phase 2 trials are going ahead in a number of cancers for 2004 and 2005. So, summary. No treatment for hormone refractory prostate cancer has as yet been shown to improve survival in a randomized controlled trial. So I think you should consider observation and palliation of symptoms, especially with radiotherapy, adequate analgesia. In fact, if somebody comes in with severe pain, I don't jump to chemotherapy. I actually give them radiation first, get them settled down, then on to the chemotherapy. Second-line hormonal therapy benefit is not well defined, but it really has been established as standard practice, and I think is best suited for asymptomatic patients or chemo-ineligible. Bisphosphonates, only zoledronic acid has been shown to be of benefit. I don't think using any of the other bisphosphonates makes any sense. But the patient benefit and cost effectiveness are debatable. Chemotherapy is active. Mitoxantrone is still a useful drug, but Docetaxel is taking over as the standard. And we'll see it, I think, going into a lot of earlier disease, adjuvant, neoadjuvant, and androgen-dependent recurrence. And clinical trials of novel therapies are always important. Thank everybody, and that's it. Thanks.
Any questions for Kim? Your spectrum of hormone refractory cancer, what do you think is the ideal time to start on early versus symptomatic?
I think it should be early. I wouldn't start somebody with just biochemical hormone refractory disease because they can have extended survival, 24 to 36 months. So giving the chemotherapy then doesn't make any sense. I think I'd like to start early in patients with metastases, but it's individualized. If I got a guy that's diagnosed in 92, and he's 14 years out with metastases and he's still doing okay, I'm in no hurry to give chemotherapy. But if a guy was diagnosed in 99, Gleason 9 disease, hormone refractory after 1 year, has METs now, asymptomatic, PSA doubling every 4 weeks, I'm going to start him on chemotherapy because I know he's going to go soon and he's going to tolerate it better if I give it now, and he'll have a greater chance of response if I give it earlier rather than later. So my preference is to start early.
Story on the non-steroidal anti-inflammatory. There's some studies being done in cell death.
Yeah, the only stuff I'm actually aware of has been more they've been using the higher doses with the sort of metronomic therapy for the hormone refractory disease, using low doses of daily chemotherapy with high doses of some of the COX-2 inhibitors as kind of an anti-angiogenic effect. And those trials are just starting up. I know they're going on in Sunnybrook and PMH. They're doing them as well, but I don't know any of the results from them. I think it's too early.
So, Peter Goot, have you heard about his work at the agency? He's been studying the effects of sulfasalazine, which is sort of consistently related on different cancers. It turns out that it has some activity against prostate cancer, again, experimental systems. It would be such an easy drug to try, too.
Yeah.
I think the problem with it is delivery, because it's not absorbed from the gut very well. Apparently, if you use antibiotics, it's some cases there. Sulfasalazine. Very old anti-inflammatory drug.
Yeah. I think the ideal populations to be studying these, for example, is the biochemical only hormone refractory, because I think a delay in progression is an easy endpoint to achieve. If you're talking about cytostatic agents rather than cytotoxic agents, if these patients are well enough that you can give, there's time to give these doses, so you can get it in there. So I think that's, I'd like to hear more about it, and certainly it's easy. There's lots of these patients out there. These trials go off really quickly. I think it's a stage migration. We're just picking it up earlier. We're more aware of it. Patients are more aware of it. Instead of showing up with extensive boning metastases, they're showing up with a single bone metastases. There's been a lot of prognostic factors looked at. And if you look at sort of the typical patient, I think, from the PR6 trials or our NCIC Canada trials, and you look at their characteristics, they fit that sort of end-stage 10-month survival. But in the States, for example, there's a trial of CAVE plus or minus strontium at MD Anderson. The average PSA, median PSA was below 10 in those patients. They were using chemotherapy plus strontium in patients with metastases. But their median PSA was 10. So as soon as they become hormone refractory, boom, they're getting chemotherapy. So I think it's...
In urology, we're often taught in animals, etc., that the average life expectancy of someone with hormone refractory hematologic disease is 8 to 12 months.
Hormone refractory. Yeah.
That's
the symptomatic. That was the past. I think that was 5-10 years ago, and I think now.
We'd be telling our patients now, because they're asking them before we refer them on to medical oncology, what's my prognosis?
There is prognostic factors out there and actually tables to determine that. But I think if you have an asymptomatic hormone refractory with METs, it's probably in the range of 18 to 24 months. If they're symptomatic, it's still that 10 to 12 month range.
Just a comment, just because of my own vested interest, but not Larry's too. But I think another way of looking at hormone refractory disease is prevention, and that is the maintenance of androgen dependence. And a lot of these therapies that have preceded the hormone refractory state are really the old therapies, orchiectomy and continuous androgen withdrawal therapy and so on. And I'm still intrigued by the possibility that the intermittent androgen suppression approach really delays progression to hormone refractory state, because currently we have patients, as you know, who are maintained on those regimens for over 12 years now, but still hormone-dependent disease. So.
Yeah, I would agree. And taking some of these novel therapies that are pills that are easy to take, and actually getting it into the intermittent therapy, extending that treatment interval, off-treatment interval, I think is actually quite exciting. And we can think of a bunch of designs, like a randomized phase 2 crossover design, where we actually look at extending that interval of treatment with these novel therapies on top of that. So I'd have to wait till those intermittent trials are done, the randomized trials. Even if it's equivalent, it still gives us a basis to try some of these new things in that